are passionate about helping people with their health and also saving lives, I would like for you to do this with me this morning to get us energized. On the count of 3, I would like for you to say, I'm ready and I am AltaMed. If you are passionate about healthcare, helping people in this community improve their health and saving lives, I want you to say this with me. Stand up and say this with me on the count of 3. I'm ready and I am AltaMed. 1 through, in your loudest outside voice with the greatest vigor, I want you to say, I'm ready and I am AltaMed. 1, 2, 3. I'm ready and I'm AltaMed. 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 Awesome. Williams, and I am the Director of Education and Training for AltaMed. Really excited to be here, and our commitment is to help you with your continued pursuit of doing just that, helping improve the lives or enhance the lives and health of people within our community. As you know, one of our top core values is our employees are our most valued asset. And with that, we're committed to your professional development. And in partnership with the University of Phoenix, we have the opportunity to sit with them, share with them what the organization's vision and mission is towards continuous improvement and professional development, and they've enrolled in our vision, the University of Phoenix. So with that, I would like to introduce to you your facilitator for today and partner in success, Juan Navarez, right? Juan Navarez is the University of Phoenix faculty member who has received the most desired Faculty of the Year award more than any other faculty member in the history of the university. Needless to say, the University of Phoenix students love him. He knows how to explain things in a way that students learn and remember. That's important, right? Currently, he serves as the Nurse Educator, Hospital Preparedness Program Coordinator for the County of San Bernardino, Inland County's Emergency Medical Agency. Appointed to the organization operational area county emergency medical care community, Jerry interfaces with fire, police, ambulance service providers regarding disaster preparedness. Jerry, as he likes to be known, earned his BSN and MSN at the University of Phoenix and has been a faculty member there for over 9 years. One of his obvious passions is the training of the new generation of healthcare staff. Please join me in welcoming Jerry with our most awesome.
Any questions before we start what we're going to cover today? You saw the agenda. I want to address those right away. And I will tell you this, those of you sitting in the back, I thought you were going to get away from not having to do much. That's where I pick on for the interactive part. Okay? So thank you for volunteering. Okay. There's some policy, there's a policy here in our way. Just make sure, I don't know if you want to say something about that. No.
So for the policy specific to medication administration, you all know how to go into the town square to pull our policies. So the policy specific to that process is HR Nursing 003. So if you need to reference that, it's listed and it's available through town square.
Because I'm actually not going to cover the actual policy, just components of it. We'll talk about those pieces as we go along. Okay, so today our objectives are really how we're going to administer medications according to policy. Who wants to venture a guess or maybe an informed response as to why we have to have policies concerning everything that we do? What do you think? Anybody? Come on. Oh, good.
To ensure consistent quality of delivery of service.
Okay. What else? Yes, ma'am.
Safety.
Yes, safety for whom?
The patients.
And absolutely, and to safeguard the organization. So policies are very important. They really outline exactly the procedure that we're supposed to use whenever we're doing any kind of procedure or anything having to do with patient care. So I've been a nurse a long time. I got most of my acute care experience at Loma Linda University Medical Center. And the first week of my orientation was, here, read these policy manuals. Oh my gosh. If you have insomnia, that's a good way to go to sleep because you can't retain that kind of knowledge. The most important thing I think you can take from all this is, where do I find the information when I need to reference it? That's the key. So if you know where to do that, does everybody in here know where you can go to reference your AltaMed policy? Yes, good. So that's the most important point. If you're not sure about something, go review the policy before you actually do the procedure. Who can verbalize the 8 rights of medication administration? Anybody brave? We're going to go over it anyway, that's okay. So don't get stressed out. And then we have to do 3 safety checks. Who can tell me what the 2 patient identifiers are? Anybody? What is it?
Name and date of birth.
Patient name and date of birth, very good. They get extra points. Understand the different routes of medication administration, because there's multiple routes that we can provide medication, right? Okay. So here's the policy, and here's the purpose. The medication is administered safely and appropriately to all patients, and it really gives us the documentation, how to do the communication piece, all the guidelines for the effective medication, and then our administration, and then complying with all the regulatory requirements. I will tell you this because I work for a regulatory agency at the local level, at the county level. Healthcare is the most regulated industry, other than, the only thing that's more regulated than us is the nuclear industry, nuclear power. But everything else, we're the most regulated industry there is in the country. So we have to comply with a whole lot of laws. In California, it's even more important because we're such a litigious state. People will sue for just about anything in the state. So we have to be really careful about what we're doing to protect ourselves, our patients, and our organization. Okay. So according to AltaMed, here's all the approved scopes of medication administration for each of the categories of practitioners, clinicians. So the registered nurse, the LVN, and the medical assistant. Are there any questions on this particular slide? Are most of you familiar with this? Yes, no, I've never seen it before.
Yes.
Okay, good. So this really speaks to your scope of practice for your particular discipline, correct? So we're all part of nursing to some degree, but medical assistants can only do certain things, licensed vocational nurses can do a little bit more, and then registered nurses can do more than that. How many of us can administer medication without a physician order or nurse practitioner order? Nobody? Good. Because some people think that we can because if we're independently licensed as a nurse, we can do that. We can administer the medication, but we still have to have an order. All right. So that leads us to this slide. The written order is required. So really, you have multiple methods. You have written orders as well as electronic, correct? Right. Okay. So how else could you get an order from the physician? Verbal. And is that allowed by your policy? No. Very good. You guys are more well-versed than I thought. That's
They
really
were
good.
trained well.
Yes. I'm very impressed. That's great. So it must include the following. All of these pieces, the patient identifiers, the name of the medication, the dose, the route, the frequency of administration, the date, time, and the electronic signature of the clinician if they're not present to sign the order themselves, right? So is that the only way you get them now is all electronic? For the orders, they don't do any more written orders at all? Okay. So they'll never see a prescription pad
Yeah, so
here?
we don't do blended medical orders.
Okay.
All electronic.
That's all electronic. And so what does the physician electronic signature look like for you guys? Right, so they sign that it states that on the, so if that were blank, and if that isn't identified clearly, then do you really have an order? The answer is no, because they haven't signed it, correct? Okay. So, I remember when I used to be on the floor, we could get electronic orders, but we would have to hound we were a teaching facility, we'd have to hound the residents. Please sign your order, please sign your order, I need to get the medication, right? Okay. Any questions on this part? You guys seem like you're very well versed in this. Okay, good. What about questions regarding the medication order? How many of you think you have the right, I'm going to go even further than that, the responsibility to question an order if you have a question about it? Every single one of you should raise your hand. You have a responsibility to your patient to make sure that what is actually written down is what the physician really wants for that patient. If it sounds funny or weird to you, call the physician or the practitioner and ask them, is this really what you want to do? That's actually a responsibility here. Because who is responsible once the medication is administered for that if it was an error? Yes, the person that gave the medication. I don't know about you, I love my nursing license, I intend to keep it. So I don't ever want that to be a problem for me. So to protect yourself, primarily, you want to make sure that you understand the order and it's really what the physician or the practitioner really wanted. They're human beings, they make mistakes. Sometimes the way it's translated, an extra zero gets put in there, so the dose may be too high. There's lots of different reasons that there could be a problem with the medication order. So if it just doesn't sound right to you, and you look it up and you go, it just doesn't seem right, then go ahead and ask them. How open are your clinicians to that? They're okay with that? Good. Because we can all make mistakes, and we all do it on a regular basis, so most of the time it's just an error. But I will tell you this, there are medications that are used outside of their formulary, their normal formulary approved formula, but for lots of different reasons, so you can do that. I came from the HIV/AIDS world, I used to run the clinics for the county, and in the early days of the epidemic, we used to use a lot of medications that were not really found in what they were truly approved for the FDA. So sometimes your clinician knows that and they're able to do that. But just keep in mind that you do have a duty and a responsibility, and you do have the right to question those, okay? Any questions on this part? And again, can you accept a verbal order? No. Perfect. Thank you. So those are one of the, we used to be able to do a lot more verbal orders. We can't do that as much anymore. But healthcare is changing. So here's your policy. You can never take a verbal or telephone order. And primarily we found over the years that this is probably one of the areas that provides the highest risk to everybody, the patient, you, the facility, because you can make a mistake in verbal orders. How many of you have ever experienced where you're a witness to an accident, and if you listen to the other witnesses, there's like 10 of you that witnessed the accident, and you interview all 10 of them. By the time you get to the 10th person, did we all see the same accident? You know, it's really an interesting phenomenon that happens. So. Okay, let's talk about the 8 rights of medication administration. So the real purpose of this is so you're increasing the safety of administering the medications correctly. You're really checking and double checking everything along the way to make sure that you're doing exactly what the clinician wants done. All right? So let's go through those. Right patient, right medication, right dose, right route, right time, right reason, right documentation, and right response. So let's talk about each of those individually really quick. Right patient, how do we determine it's the right patient? Name and date of birth, perfect. You know, every time I go to my clinician's office, because I'm a diabetic, so I have to go see my doctor at least 4 times a year, and I walk in, they all know me by name and everything, they always ask my date of birth. I'm like, you don't know that by now, but I get it. They're doing their job. Right medication. We already talked about that. You're going to look at the order, make sure it's exactly what it's for. Most of you know a lot of your patients well, and you're like, why are they getting this medication all of a sudden? Something weird. You know, we want to talk about that. Is it the right one? Could have been a mix-up, because sometimes and we'll talk about look-alikes in a little bit, or sound-alikes in a little bit, because a lot of medications, their packaging looks similar, their names sound similar. It's a really easy area to make a mistake in. Right dose. We talked about that as well. It could be as simple as adding an extra 0, right? Or a period in the wrong place. How about right route? What do we mean by that? What do you guys think? Oral versus IM or? Right, so there's a lot of different ways that we can give medication. So we really need to make sure that this is the correct route. Now, what's the fastest way, what route is the fastest uptake that the body absorbs medication? Well, some people saying sub-Q, some say IM. What do you think is the fastest? No, oral. Anything that goes into your mucosa gets absorbed very quickly in your body. The only fastest way is if you go IV, but you guys don't really do that in your clinic. Okay? That would be the only faster way. So that's really important to understand. So if you're giving somebody oral medication, like sublingual, and you're letting it dissolve in your mouth, you may see some side effects sooner than you would if you give them a shot or anything like that. Okay? What about right time? What do we mean by right time? What do you guys think?
Like your medication on like the same time.
Okay, we'll try to be consistent. But you know, I teach a lot, so I work these really long days. So sometimes my 7 p.m. medication, I don't take it till like 10, 11 o'clock at night. I'm a 9 o'clock patient, I know that. But that's part of the time. What else is the time? Within what time frame? Do you guys have a parameter for that? So let's say you come in order as soon as you possibly can, right? So you really don't have a parameter. Now in the hospital, sometimes you have parameters. You have to have like, that should be administered within an hour or those kinds of things, because it's there's a time limitation to how effective the medication will be. But that doesn't really apply to you in the clinic because you're all outpatients, right? Okay. But what else can we talk about time? So if they're taking the medication like I'm supposed to be at twice a day, and I should take it at the same time every day, or as close to that as I possibly can, right? I even have a reminder on my phone that beings that tells me, take medicine. Oh yeah, I gotta go do that. So, what else is there? There's something else I want to talk about for time. Yes, ma'am.
Well, if patients speaking their guts out, it would not be a good time to give oral meds.
Yes, very good. Because they're not going to keep it in. They're going to just, so you may want to go back to the clinician and ask, can I give this by a different route because this patient is vomiting, actively vomiting at this point. So that's another consideration you need to think about. Is this really going to be the most effective way for us to give this medication at this particular time? Okay. What about reason? Yes, ma'am.
Well, especially with pain meds, you want to make sure they're really getting it for pain and not for fun.
Is that our responsibility?
somebody freaking flyer and they come in and
Yeah.
they get the float provider to write them Norco, but we know they just got Norco last week. We should bring it to the attention of the provider.
Exactly. You're exactly right. Bring it to the attention of the provider. But do you guys provide outpatient substance abuse services?
No.
That's not our function, so that's not something we should focus on. I agree, you make the provider aware of that, but maybe they're not aware of that, that this person or this patient potentially could be abusing the substance, and that's an important consideration, because that's part of your history and your intake and your assessment that you're doing. However, we need to focus on what our particular function is. Why is this person here today? They're here because they're nauseated, they're vomiting, they're sick, they have the flu, whatever the heck the reason is, and then we give all that information to the provider. So if we suspect substance abuse, what's the best course of action? Tell the provider, hopefully they'll get a referral to those services, right? Okay. What about other reasons for the medication? What other reasons? What if they're in here for nausea and vomiting and they're getting something for, let's say they're scheduled for surgery and you're supposed to take their go lightly and you're going to give them their go lightly so they can evacuate. Is this probably the right time to be doing that? No. So those are the kinds of things that we're thinking about, the right reason. Documentation, what's the right documentation? For you, you seem to have one set of documentation, right? And all of your clinics are connected to the same system so you can see everybody? So regardless of which location they go to, right? Perfect. That makes it even better. So all your documentation has to happen there. So what's the unwritten rule in healthcare? If it isn't written down, it didn't happen. That's correct. Because I'm going to tell you right now, in my career as a nurse, I've had to go to court a couple times to testify for lots of different reasons. Most of the time it's would a reasonable, improved individual do the same thing in the same circumstance? Not because I was being sued, but luckily I didn't have to do it. But let's say you go to court in 5 years from now, the only thing you have to rely on is your documentation. Unless you have a super memory, which I do not. The older I get, my memory gets worse and worse and worse. You're only going to be able to rely on your documentation. As well as your facility, that's the only thing they're going to rely on, right? What happened, this is what happened. What about the right response? What do we mean by that? Yes, ma'am? You need to sit in the front.
Okay. No, I like it back here.
Okay.
Right response, we want to make sure that the patient is not having anaphylactic reaction of any sort, whether it's hives or
Right.
nausea. And you want to make sure, for instance, if you give them compliance, you want to check their blood pressure, make sure it comes down in 15 minutes, 20 minutes.
Right. So how long should we hold them for? 15, typically 20 minutes or so. I look at, there's a new slide coming up that will talk about that. But yeah, 15, 20 minutes is usually adequate. You're going to see some sort of reaction at one time. And you're looking for all kinds of signs. You're looking for any kind of reaction the patient's having, even if it's not full-blown anaphylaxis. Have any of you ever experienced a patient who has full-blown anaphylaxis? Yes, ma'am. It's pretty scary.
Yeah.
Their throat closes up, they can't breathe. If we don't intervene, it will die. Yeah, absolutely. We do this in EMS on a daily basis. People have all kinds of reactions to stuff. But usually in the outpatient clinical setting, it doesn't happen as often, thank God, but it does happen. So we want to, and are patients really okay with, what do you mean I'm going to hang around for 20 minutes?
No.
They don't like that. So we should give them something to do. Watch TV or give them a quiz or something. To make them stay there for 20 minutes, right? All right. So we're going to talk about the right patient. We already talked about that, full name and date of birth. You guys do that very well. There's a note on this slide that talks about, this is a great time to ask them about any allergies they have. Because a lot of times people, they know they have allergies, but if they don't ask, they're not prompted. It's difficult for them to remember. I remember my mom, before she passed away, she would go to the doctor quite a bit. And at that time I was in nursing school. And she would come back and say, well, what did the doctor say about this? Well, I forgot to ask him. Well, what did the doctor say about that? Well, I didn't talk about that. And this is so I went to a couple of my mom's visits, and here's what happened. I got her permission to go into the room, and he was questioning her, and she would say, so, how are you doing today? What would you think her response was? Fine. Well, then why are you here? But the point is if you don't prompt them, it's going to be hard sometimes because they get nervous and they don't want the doctor to know, especially that generation of my parents, the older folks, which I'm becoming one of those people. They, we have this tendency to, well, the doctor's going to get mad at me, and they're not going to, I don't want them to get upset and shoot me out, so I'm not going to tell them about that. So we really need to ask them questions and prompt that information to try to get it out of them. So ask about allergies. How many of you know your particular allergies to medications? Okay, if you don't, thank God you haven't experienced it yet, but if you ever get a medication allergy, remember that. I'm allergic to erythromycin and anything with codeine. It just makes me really ill. Rarely do I throw up, but it makes me really ill. So I make sure I let everybody know. Because a lot of times they want to give you Vicodin or something else for pain, because I've had surgery in both knees, and I injured my back, that's why I don't do bedside care anymore. And so for chronic pain management, Vicodin is a pretty good drug of choice. I don't do well with it. It makes me feel horrible, so I don't take it. So it's a good time to really prompt them about that. How are we doing on time, okay? Medication, we talked about that. There's another one that we want to look about. So you're verifying 3 times. Once when you're removing it from the storage area. And where do you normally store your meds?
Cabinet.
There's a cabinet? Okay, so that's where you're going to pull the med from. And then so when you remove it from the container itself, you should check the container, is this what it says it is? Because there's a lot of containers that look very similar, especially if you're drawing things up. And then after preparing the medication, but before you give it to the patient, re-verify it. Most patients, and this happens to us on disasters, they come to the shelter without their meds. They evacuate without their medications. This happens a lot. And you're asking them, so what medications are you on? Well, I take a blue pill, and I take a red pill. So we have these huge charts of all the different kinds of medications as part of our emergency response. I go, okay, can you tell me what your pill looks like? And we try to narrow it down from that. It's really hard to do. So a lot of pills look very similar. That's why I'm kind of making a big deal about this, because it's really difficult to get people to understand that a lot of medications look the same. This is a big deal right here, because what happens if you give somebody a medication that's expired? What's that? It could lose its efficacy over time. Rule of thumb, just so you know, but I'm not advocating this. The FDA says that really these are good for double the life that it says on here. But they have to have a cutoff date. So, but what's the result for you as a practitioner? If you give somebody a medication that's expired, what do you have to do once you discover that? You have to do an incident report. Why is that? Well, correct. And it's self-reported. And are you going to get fired because of that? The answer is no. Because we want to know that as part of our QI process, right? We want to know what we're doing, what we can do better. But the real reason is so that we can document, and the physician or the clinic, whoever the provider is, really clearly understands that this happens, and they can monitor the patient for any adverse effects. That's really the purpose. So it's not because we want to punish people, we just want to make sure. So rather than get involved in that process and have to file an incident report and all that, just check the expiration date. And I know it's an additional step, but we have stuff that happens to us all the time. Every one of us in our world has an emergency kit in their car. And guess what happens? All of our medications like ibuprofen, aspirin, all that in our kits, they all expire on a regular basis. And we're like, I'm going to take it anyway. But I can choose to do that. I can't give it to you and have you take it, right? So that's an important component. All right. What about the right dose? We talked about that. Dose is too small and not produce the therapeutic effect. You all understand about therapeutic levels in the bloodstream? Okay. It takes every medication that we have has been tested for its efficacy, how fast it gets to the therapeutic level in your bloodstream, how long that stays at that therapeutic level, and then when it starts to drop off. That's why most pain medication is given how often? Every 4 hours. Because that's the tip, that's the average for most pain medications that have the highest peak effect in your bloodstream. Okay? So that's an important thing. Doses too large to be harmful or even fatal to the patient's fitting. You guys do pediatric patients?
Yes.
Yeah. That's really important with children. We say in emergency management, most of us think that children are just small versions of adults. They're not. Their physiology is very, very different. And so we have to be concerned about how they have to take medications in a different way. Biggest thing you need to know about, this is just kind of information for you, that you need to know about children is their head to body size is way different than for adults. So they lose a lot of heat, they lose a lot of moisture from their head. So that's one of the things you have to be concerned about. That's why you really should cover like babies' heads and all that stuff when they go outside, because their head circumference size to body size is very different than an adult. So if you don't, even if you don't feel cold or any of the effects of the weather, children have a much different effect or a much different response. Okay, we talked about the route. I don't want to beat this to death. So you guys do injections like vaccinations and all that kind of stuff? Okay, so what are some of the things that we're really looking for when you're administering an injection? Let's say you have an order for IM and you have a child. What's the biggest needle problem you should use? 1 inch. Why? They got little skinny arms. The muscle mass is not great. What needle would size would you pick for me? Probably 18 gauge, 2.5, right? But, so that's the whole point. Really starting to look at it. Sub-Q, how many layers of skin are we looking at?
The first one.
The very first layer? If you can do the first layer, I want you to teach me how to do that, because that's a tough thing to do. Usually, you're usually into the second and third layer of skin for sub-Q. But as long as you're not in the muscle, that's really all that matters. So that space, when you're in the skin, just underneath the skin but above the muscle, that's what we're looking for. Sub-Q is under the skin. We call it subcutaneous. Cutaneous is the skin, our biggest organ in our body. Okay? And then IM goes right directly in the muscle. What happens if you aspirate and you get a little bit of blood back? What do you think?
You're in a vein.
You could be in a vein should you pull out and relocate. Probably. Or pull back a little bit and then you can still administer in that same spot. I just got my flu shot about a month ago, and because I was sick, they were giving them and I had to wait. But my arm was sore for a little while. I had a little bit of a knot. And that's not unusual because the vaccine is kind of viscous this year, unfortunately. So that's not unusual. But if I started having a lot of redness and complaining of soreness, what do you think is going on with me? I'm having a reaction. So I need to tell the clinician that they probably would want me to come in and take a look at it because it could cause problems. And there have been, most of you are probably way too young. Way back in the 70s, we had swine flu vaccine that actually caused a lot of problems and actually a few deaths across the country. So there are real reasons that we want to know if anybody's having a reaction.